Hello, my name is Doug Burgoyne, and welcome to today's webinar, Individualizing Advanced Metastatic HER2-Positive Breast Cancer Care, Evidence-Based and Patient-Centered Approaches. This activity is provided by Prime Education in collaboration with Novelia. There is no fee to participate. This activity is supported by educational grants from AstraZeneca Pharmaceuticals and Daiichi Sankyo, Inc. Our faculty presenting today's webinar are Dr. Reshma Matani and Dr. Rita Nanda. Dr. Matani and Dr. Nanda, would you please take a moment to introduce yourselves to our audience?
Sure, happy to. I'm Reshma Matani. I'm Chief of Breast Medical Oncology at Miami Cancer Institute, Baptist Health, South Florida. Glad to be here today.
Hi, and I'm Rita Nanda. I'm the Director of Breast Oncology at the University of Chicago. A real pleasure to be here with Dr. Matani.
Outstanding. We're looking forward to your presentation today.
It's a pleasure to be here with you all. Let's start with one of those polling questions we mentioned that we would be going through. So the first one is, what is your biggest challenge in managing advanced metastatic breast cancer? Aligning treatment with rapidly evolving clinical evidence and guideline recommendations, individualizing treatment selection and sequencing based on patient, disease, and treatment-related factors, activating patients in their care through education and shared decision-making, or D, monitoring for and managing treatment-related adverse events associated with novel therapies.
Outstanding. Thank you. The poll has now opened. You can see that has popped up on your screen. Please take a moment to answer the question using A, B, C, or D, whichever response you think best fits the question. What is your biggest challenge in managing advanced or metastatic breast cancer? Dr. Matani and Dr. Nanda, there's a lot going on in breast care and breast cancer. Last week at SABCS, there was probably some new information that was released. I don't want to give anything away from today's presentation, but anything that you're excited about that's coming up.
Rita, do you want to tackle that, or would you like me to start?
Yeah, I think that there were a lot of interesting studies that were presented at San Antonio this year. I think that, some of it pertained really to early stage breast cancer. So it's exciting to see that some of the therapies that we're using in the early stage are curing more patients and leading to less metastatic disease. So that's really great to see. But I think that we've come a long way with the therapies that we have for advanced stage disease. So it's really exciting to review these topics today.
Outstanding.
Yeah, I agree. And I think as we go through the presentation today, we'll hopefully pepper in some of the newer information that we heard about, especially in the sequencing of HER2 positive disease and some of the newer data sets. And of course, we'll walk through strategies for advancing some of these common challenges that are listed here in this polling questions. So, do you want to give the summary of the poll?
You got it. The poll has closed. Thank you, everyone, for your participation. And it's pretty evenly split. 39% of our respondents selecting option B, individualizing treatment. 30% option A, aligning treatment. 22% monitoring and managing treatment. And then our trailer is activating patients in their care through education and shared decision-making. So looks like it's B, A, D, and C in that order.
Got it. So again, today we'll be going through some of the strategies for addressing some of these common challenges, and just highlighted in the responses that we heard from this polling question is the fact that taking care of breast cancer patients is complicated. There are a lot of things to factor in. And with that, we can go to the next slide where we get into some of the discussion. I'm having a little hard time advancing the slides here. Okay, there we go. So as mentioned, we've made considerable progress in treating metastatic disease. And indeed, our death rates are falling from metastatic breast cancer and have steadily declined over the past several years. A lot of that, of course, is due to progress that we've made in early stage disease and finding cancers earlier. But a lot of the progress has also been with regards to the development of novel therapies. And that success story has really been highlighted in the treatment of HER2 positive disease, where we've made a lot of progress. We know that about 15% of breast cancers have amplified and overexpressed HER2, and this means that this is a more aggressive subtype of the breast cancer with an overall worse prognosis. But the way I would describe it is it's sort of a double-edged sword, because although the biology is more aggressive, we've made so much progress in targeting HER2 that this has in fact led to the development of multiple therapies for this subtype and has directly led to our declining death rates. Despite the treatment advances, ultimately most of our patients do develop progressive disease, and that highlights the need for additional novel therapies, with one area that's of particular concern, which is the development of brain metastases, where we know that a considerable proportion, almost half, according to varying based on the series that you review, do develop brain mets during their treatment course. And as highlighted again by the poll that we just went through, with many different treatment options available, it's important to take an individualized approach to treatment selection and sequencing based on patient disease and treatment-specific factors. So we certainly can't take a prescriptive approach to care here, and when we see a patient in front of us in clinic, we take a lot of these things into consideration when individualizing our treatment choices. And those are highlighted here, some of the things that we take into account. Of course, the individual sitting in front of you, how old they are, what their comorbidities are, what their preferences are certainly things that we factor in. But then, of course, how symptomatic they are from their disease, where their sites of disease are, and what biomarkers are the biomarkers that we have, which can certainly help guide our treatment choices, such as whether the tumor is ER and PR positive, where hormonal therapy can be used. Of course, we're focusing on HER2 positive disease in this program today. And then with the availability of newer targeted treatments, where we're still looking for biomarkers to help us select those therapies. Of course, treatment factors certainly come into play in terms of the safety profile of many of these drugs, and it's becoming increasingly challenging as we're seeing newer treatments with unusual side effects like eye issues, hyperglycemia, rash, all of these things. Of course, as oncologists, we are learning how to take care of some of these other issues based on these newer treatments. So with that, let's get into a discussion on aligning clinical practice with the latest clinical evidence and guideline recommendations for patients with advanced HER2 positive breast cancer. And here you see the NCCN guidelines for advanced HER2 positive disease. First line setting, we have the availability of a taxane with dual antibody therapy, pertuzumab and trastuzumab, as our standard treatment for first line patients. This is really based on the Cleopatra trial, where we did see a considerable improvement in efficacy with the use of pertuzumab when added to taxane and trastuzumab. We saw a survival and a progression-free survival benefit that was very meaningful. In the second line, for many years, our go-to was trastuzumab emtansine until trastuzumab deruxtecan, the newer ADC, is now more recently the standard in the second line, and we'll go through some of the data that led to that approval or that indication. And then, of course, third line, we have various options that are shown here, with most of us considering the tucatinib regimen in combination with trastuzumab and capecitabine. And we also have the availability of TDM1. Of course, the activity of TDM1 post-TDXD is something that we certainly need more data on. I should also mention that the tucatinib regimen is an option for patients in the second line and is often considered, especially in a situation where an individual has a CNS burden that is considerable. And of course, Dr. Nanda and I will get into those discussions further as far as how we're incorporating this algorithm into our clinic. You'll notice that fourth line and beyond, you see some of the newer agents like margetuximab, but some of the other drugs that we had previously used more frequently, like neratinib. I'm personally not using as much neratinib in the metastatic setting now since we have tucatinib available, but I'd be curious to hear what you're doing, Dr. Nanda, as well in that regard. And then, of course, we have standard chemotherapy in combination with HER2-targeted treatment. So let's go through some of these data sets. First, I had mentioned that trastuzumab deruxtecan has now become our standard second-line option. It was initially approved based on a study that's not detailed here, the DESTINY-Breast01 trial, which was a single-arm, non-randomized phase 2 study of patients that had progressed on TDM1, and we saw a really impressive overall response rate in that population, and it really led to us looking at this as a treatment earlier on, head-to-head compared against TDM1, which had been our standard in the DESTINY-Breast03 trial. So in this study, patients that had previously received trastuzumab and taxane were randomized again head-to-head TDXD versus TDM1, and as summarized on this slide, we saw a very impressive median PFS of 28.8 months with TDXD as compared to 6.8 months with TDM1. I think this is especially impressive, recognizing the data that we saw in the first line setting where we didn't see a median PFS that long. And so, this is something that I think has become very clinically meaningful in our standard second line treatment. We saw the survival benefit as well. And of course, we do worry about the ILD issue with trastuzumab deruxtecan. In this data set, there were no patients with grade 4 or 5 ILD pneumonitis, which was reassuring. All grade was about 15%. Whether the lack of higher grade events was related to a patient population that was less heavily pretreated or not remains to be clarified. But again, this is a side effect that we all have to be mindful of, especially when we're counseling our patients on things to watch for. So DESTINY-Breast02. This was a study that was required to be done. Of course, we were already very comfortable with TDXD, having received the information that I just went through with the DESTINY-Breast03 trial, where we were already using TDXD, but this was a study that was required to be done, the randomized phase 3 trial, where it was compared against capecitabine plus trastuzumab or lapatinib. And here, again, not surprisingly, we saw an improvement in PFS, 17.8 months versus 6.9 months, with improvements in survival noted here as well. Now, again, in terms of toxicity, we saw some ILD here and treatment-related emergent AEs that were associated with discontinuation, 14% versus 5%. HER2 Climb 2 is an important data set, or I'm sorry, HER2 Climb. I'm already alluding to the newer data that we heard at San Antonio. But this is the study that led to the incorporation of the tucatinib regimen. This was a study that looked at patients that were treated in the metastatic setting previously with drugs that we are frequently using, trastuzumab, pertuzumab, as I mentioned, first line, and even TDM1, which had been our second line regimen. This was a large randomized phase 2 study in which the tucatinib, trastuzumab, capecitabine regimen was compared against placebo, trastuzumab, and capecitabine. And what we see here is an improvement that was quite modest in terms of median PFS, but we did see an improvement in overall survival and overall response rate. And what was really quite nice to see in this trial is that there were a large percentage of patients, almost half, who had brain metastases, not only stable brain metastases, but even active brain mets. And in an updated exploratory analysis in patients with brain mets, again, we saw an improvement in median overall survival and median CNS PFS, which is, again, a clinically meaningful endpoint, specifically looking at progression in the CNS, was also favoring the tucatinib arm, as shown here. As I mentioned previously, when we were looking at the NCCN pathway, neratinib was listed as an option in combination with capecitabine for fourth line and beyond. That's based on the NALA trial. I think many of us have had some experience with this agent in the extended adjuvant setting, where we know the rates of diarrhea can be really high, and we very selectively use this agent in the early stage setting. There is data that's summarized here in the NALA trial that also led to the expanded indication in the metastatic setting in combination with capecitabine. Again, here, diarrhea is a bit of an issue, and in this trial, loperamide prophylaxis was actually mandated for the first month of neratinib treatment. These were patients that had had two or more prior, at least two prior HER2-directed therapies, and what we did see was an improvement in 18-month PFS, 16% in the neratinib plus cape arm compared to the lapatinib cape arm was it was 7% 18-month PFS, with the overall response rate favoring the neratinib arm, although numerically higher median OS did not reach statistical significance. And then, of course, we have this new agent, margetuximab. So just by way of background, margetuximab is an Fc-engineered HER2-directed monoclonal antibody. And here, this agent was compared against trastuzumab. Both, again, were given in combination with chemotherapy in HER2-positive patients that had received at least two or more lines of therapy in the metastatic setting. And what we saw was a very small magnitude of difference in terms of median PFS and no overall survival benefit, although there was an interesting difference in OS that was noted based on differences in CD16A receptor alleles. And that was based on a pre-specified exploratory analysis where there was a numerical OS advantage in favor of margetuximab in the subgroup of patients that were homozygous for the CD16A F allele. But of course, we're not using this information in clinic currently to make these decisions. We're certainly awaiting other data sets like the investigator-initiated study, the Margo trial, where we're looking at the activity of margetuximab in patients with specific variants of CD16A. So this is another available agent in combination with chemotherapy for our patients. So with that, let's go through a patient case. This is a 53-year-old woman who presented with de novo metastatic hormone receptor negative HER2 positive breast cancer with bone metastases. She had no significant comorbidities, and she began treatment with trastuzumab, pertuzumab, and a taxane, in this case docetaxel. She responded well. After about 2 years, she developed progression of disease with new metastatic bone lesions identified by imaging. There was no evidence of CNS progression detected. So our next polling question here is with regards to what therapy you would consider next for this woman. Would you offer trastuzumab emtansine or TDM1, the tucatinib regimen, which again is tucatinib, trastuzumab, and capecitabine, neratinib plus capecitabine, TDXD or trastuzumab deruxtecan, and the final option is trastuzumab plus lapatinib.
Excellent. Thank you, Dr. Matani. Our poll has opened for our audience and our participants. Please take a moment to look at your screen and make the selection that you think best fits this case. And we welcome folks literally from around the world to today's presentation. It's great to have you here. And we'll remind you, if you have questions or comments for Dr. Nanda or for Dr. Matani, please submit those questions via the public chat. Dr. Matani, this patient seems, well, you tell me, is this a patient that you see in clinic frequently? Is this a common case presentation?
Well, I think one thing that I would highlight with this case is that she had de novo disease, which we know in the US is not as common to see patients with de novo metastatic disease. Unfortunately, after the COVID pandemic, we tended to see patients who came in with more locally advanced and de novo metastatic disease, but that's, I think, more of an outlier. Would you agree, Rita?
I mean, that's interesting. I think, well, yes, absolutely. In the United States, we see much less de novo metastatic disease. I have to say, most of my patients with HER2 positive breast cancer actually presented with de novo metastatic disease. I think now that we're using trastuzumab, pertuzumab, TDM1 in the early stage setting, I mean, I'm personally just seeing much fewer numbers of HER2 positive metastatic disease. So I think it's a little skewed towards de novo, but overall the numbers, I 100% agree, are quite low.
Excellent. Well, thank you. And our poll is closed. Yeah, it speaks to the progress.
Go
You're
ahead,
right.
sir.
You're right, Dr. Matani. That's exactly right. Looks like our poll, 51% of our respondents select option D, the TDXD, and then 23% with option B, and then trailers from there. What do you think?
Well, I think that's a nice segue backdrop to have this discussion regarding the sequencing of therapies. In this case, this individual in the second line setting had no evidence of CNS disease. I personally would be in that group that chose TDXD. I think you said it was 51% in the second line. And I think that's very well reflected in the DB03 data that we went through, where we had the option of TDXD, and we saw that median PFS being 28 months, which I think is really remarkable considering in the first line we're not even seeing that. What are your thoughts, Rita?
Yeah, no, I think I'm a little torn on this case. I would say in general, I usually do pick TDXD in that second line setting. I'll generally favor the HER2 climb regimen for patients who've got brain metastases, but this patient only progressed in the bones. And, I think that when you think about, and I'm going to talk about this a little bit later, about the tolerability of TDXD versus the HER2 climb regimen, I think this is a reasonable, I think that it's reasonable to consider the HER2 climb regimen in this setting, or even perhaps considering incorporating the taxane, because I'm sure many of you probably treat with that Cleopatra regimen in that first line setting, then end up dropping the taxane after a period of time. So I think, just in terms of trying to find a regimen that, obviously if the patient's very symptomatic, that's one thing. But if it's really just an imaging progression only in the bones, I think there are lots of different strategies that could be used. I think there's not just a one size fits all. And again, we're going to talk about that shared decision-making aspect to a case like this in my portion.
Excellent. Yeah, I think you bring up a really great point. And I think the other thing that I might consider, of course, this patient wouldn't be suitable because I believe she had hormone receptor negative HER2 positive disease, but there is the opportunity to incorporate hormonal therapy and HER2 directed treatment, and the role of CDK inhibitors, of course, in that setting is not as clear. We do have some data with that, but that would be a very reasonable strategy, especially in a patient who's ER positive, HER2 positive, and has a low burden of disease.
Yeah, no, I think that's a great point. I would say that in general, when I drop the chemo for my hormone receptor positive patients, I start endocrine therapy in that maintenance trastuzumab, pertuzumab setting. So the point is well taken about the potential to maybe switch out that endocrine therapy and add a CDK4/6 inhibitor based on emerging data, if it's covered by the patient's insurance company.
Right. So I promised that we would pepper in a little discussion of San Antonio updates. How do you think that the data with HER2 Climb 2 that was presented may change this algorithm, or will it at all?
Yeah, so I think for those of you who aren't familiar with HER2 Climb 2, this was a randomized phase 3 trial of TDM1 with placebo versus tucatinib. And the data, that were presented that were mature was the PFS. And so there was I think a 2-month improvement in median PFS favoring the combination strategy over TDM1 alone. The overall survival data were not mature, but it's unclear just from the Kaplan-Meier plots that they're really going to see an overall survival advantage. So a pretty modest 2-month improvement in median PFS. I'm not entirely sure that I think it's going to change practice, particularly if there's no survival advantage. But I don't know what your thoughts are. I don't even know if it'll get approved without a survival advantage as a regimen.
Yeah, so of course, the approval is definitely the biggest bottleneck that we face when it comes to utilizing these therapies in clinic. I think the thing that I did like about the regimen is that it does give patients the option of using IV treatment in combination with tucatinib, as opposed to the HER2 Climb regimen, where we have a pretty heavy pill burden. Of course, we have a survival benefit with that regimen, as we've just gone through. So I don't mean to suggest that we can kind of just switch out the capecitabine for TDM1. I don't think we have data to support that. But from a tolerability standpoint, I do think there are advantages there, and it may be an option for the patient in front of you based on some of the individual factors that we've already alluded to. And I think that's a nice segue. I just want to keep us on time here to the next slide, which is where I turn it over to you to discuss adverse event management.
Yeah. The only thing I did want to just briefly mention about HER2 Climb 2 before we move on is that there were some real toxicities seen with the combination of TDM1 and tucatinib. So I think before we want to think about just starting to do that in practice, it's probably worth waiting for some more mature data. That's just my personal opinion, because we certainly don't want to enhance toxicity. So with that segue, I'm going to be talking a bit about the toxicities that we're seeing and really focusing a little bit more on them. Dr. Matani really went through the clinical efficacy data really well, but I just wanted to hone in a little bit more on the toxicity, because as you all know, that is something that we need to think about as we're choosing these options for our patients. So for trastuzumab deruxtecan, we saw the very impressive improvement, not only in median PFS, but OS as well, favoring TDXD over TDM1 from the Destiny Breast 03 trial. That improvement in efficacy, though, did come at the cost of some toxicities. For the most part, these toxicities are quite manageable, but certainly more side effects than we see with TDM1, which, for the most part, patients don't lose their hair. They maybe have a little LFT elevation and some low platelets, but for the most part, patients feel quite well on TDM1. That is definitely a different side effect profile when we think about TDXD. We're seeing alopecia in the vast majority of these patients, although I have had a handful of patients who've actually had their hair come back while they're on this therapy in the absence of scalp cooling. So it's not absolute and it's not everyone, but I would say it's the majority of patients. Nausea and vomiting can certainly be challenging. This is a highly emetogenic regimen, so we definitely need to think about using our combination strategies for trying to prevent and manage nausea and vomiting in these patients. Cytopenias also can be seen. And then, as Dr. Matani had mentioned, interstitial lung disease is definitely something which is seen in a percentage of patients. I think about 1 in 6 patients experience some degree of interstitial lung disease, and there were some fatal cases that were seen in this trial. So that is absolutely something that you need to monitor your patients for, get pulse ox every time they come in, take a good history to see if there's any shortness of breath, cough, hypoxia, any issues that patients are describing that could be suggestive of interstitial lung disease. You really do want to catch this early. For those patients who develop grade 1 interstitial lung disease, which is no symptoms but just present on imaging, you can hold, wait for it to resolve, and then consider re-challenging. But for grade 2 or higher interstitial lung disease, you need to discontinue therapy permanently and consider corticosteroids or other immunosuppressive therapies for patients who are quite symptomatic. As you can imagine, any trastuzumab antibody type therapy carries that risk of decline in ejection fraction. So if patients develop shortness of breath and fluid retention, definitely think about ordering an echo and holding therapy. And then neutropenia, for the most part, can be managed with growth factor, institution, or dose reduction, or both. But interstitial lung disease is kind of the unique toxicity that's seen here, and definitely something to think about. Moving on to the HER2 climb regimen, again, much more tolerable than TDXD for sure, but there are some unique toxicities that were seen in the HER2 climb clinical trial, some hand-foot syndrome or plantar palmar erythema, I think, which we're all very well versed with and know how to manage. For our patients with capecitabine is definitely something to think about. A little bit of diarrhea, but nothing like what we see with neratinib, for example. So again, things to just monitor your patients for. Hepatotoxicity also is another toxicity actually seen at a much higher level in the HER2 climb 2 trial of TDXD plus tucatinib that we were talking about. But for the most part here, generally pretty manageable and of low grade. And you can see here that only about 6% of patients who participated in this trial had early discontinuation versus 12% for that Destiny Breast 03 trial looking at TDXD. So in general, more tolerable, a little distinct in terms of toxicities, but really diarrhea and hepatotoxicity and plantar palmar erythema are the toxicities to monitor for. Now moving on to discuss the NALA trial, which looked at the combination of neratinib and capecitabine versus lapatinib and capecitabine. I think all of you who've used neratinib know that it can come at the cost of a fair bit of diarrhea. And that is the main toxicity, both in the metastatic setting, particularly in combination with capecitabine, and then even in the early extended adjuvant setting, when it's given as monotherapy, is the main toxicity that patients will report. And it can be quite severe, the diarrhea, also abdominal cramping, nausea, vomiting, all of those toxicities, primarily GI toxicities, were the most common. And you can see that 14% of patients had early discontinuation in the context of this trial, primarily because of that diarrhea. Now, there was also the control trial, which looked at 4 different strategies for helping to mitigate the diarrhea toxicity. And so there are strategies that you can take. This is a regimen that you're planning to use for your patient. Obviously, educating patients about the risk of diarrhea is critical here. But also, considering starting out at a lower dose of neratinib and then escalating over the course of a few weeks, administering prophylactic loperamide in addition. Those are all strategies which can really help patients. In general, the diarrhea, if you can get patients through the first month or 2, gets better over time. But again, those first couple of months are critical. But I have had patients who've certainly had persistent diarrhea even after the first couple of months. So again, something that can greatly impact quality of life for patients and something that really requires a fair bit of education. Moving on to discuss margetuximab plus chemotherapy. Again, from the SOPHIA trial, this regimen was generally very well tolerated, very few discontinuations. Margetuximab is very similar to trastuzumab in terms of toxicity profiles. So decline in ejection fraction, infusion-related reactions, which are generally very easily managed, are the main side effects. For the most part, the toxicities with this regimen come from the chemotherapy. So again, something to consider if you choose to do so. I will say the data are quite modest in terms of the efficacy improvement over trastuzumab. So I would say I probably have not really incorporated this into my clinical practice. There's no survival advantage and a very modest improvement in PFS. So again, something to consider for your patients, but again, the efficacy data are quite limited. So when thinking about patients with metastatic HER2 positive breast cancer, you've seen that there are so many options here, many which improve outcomes, improve progression-free survival, even improve overall survival, which is obviously very important for our patients. But I think it's also important to recognize that all patients are different. There are different risks that these different regimens carry, and it's important to think about the comorbidities patients have and what their wishes are, what their performance status is, what prior toxicities they've experienced from therapy, in thinking about how to work with patients and offer them the best option for both improved efficacy as well as improved quality of life, which is really very important in the metastatic setting, right? In the early stage setting, we put up with a fair bit of toxicity because our goal is cure. But in the metastatic setting, we're really looking to improve quality of life and prolong life, but certainly not at the cost of very toxic regimens that minimally impact long-term outcomes. So just things to think about when we're thinking about these different regimens. And that really is a nice segue into this next block, where we're going to talk a little bit about shared decision-making. Long gone are the days of paternalistic medicine. It's really important that we as providers work with our patients and make sure that we are offering them all of the options that are available to them and helping them make the best decision for them. We've got so many different regimens for HER2 positive breast cancer. And so, as we're talking to our patients about these different strategies, it's important to help them understand that they have different options. There's not necessarily just one way to proceed. There are different treatments. These treatments come with different side effects. Having an educated discussion with patients about the pros and cons of these different regimens, how it might impact them and their quality of life, and understanding what's important to them. For example, for a teacher, diarrhea may not be the best side effect to deal with if they're in a classroom setting. And so I've certainly worked with patients around selecting regimens which work for them and work for their work and their lifestyle. Other patients want to try to avoid hair loss if at all possible, and prefer oral regimens. And so there are definitely options here, and those are things to think about, when we're discussing this with our patients. Also focusing on, is it easier for patients to come once every 3 weeks for an IV treatment, or is it easier for them to take pills at home by themselves? What the side effects are, all of those things help patients make the best decision for them. There are also a number of different factors which can impact patients' adherence to therapy. And so it's really important to consider these as we're thinking about those patients in front of us. For example, what are their comorbidities? What are their other medications they take? What is their pill burden? And are we going to tip the balance if we add several more pills to their daily intake? What are their expectations for therapies? Are there cognitive impairments or challenges with health literacy that might impact their ability to adhere to therapy? Those are all important. Obviously, anxiety and depression can certainly impact patients and their willingness or ability to come for therapy. And we can do a lot to help patients with distress, and that's important to think about. Also thinking about, treatment-related factors. What are the adverse events? Again, a teacher may not be able to have diarrhea and leave the classroom when she's in the middle of a class. Those are important considerations to take. How complex the regimen is. Sometimes for our patients who have cognitive impairments or health literacy impairments, taking 2 different kinds of pills multiple times a day can certainly be a challenge, and maybe a once every 3 week infusion is an easier strategy. So again, things to think about as we're thinking about that patient in front of us. And then socioeconomic factors, how far patients are traveling to get their care, what are their out-of-pocket expenses, how is it disrupting their lifestyle, their work, their childcare responsibilities, what can we do as providers to help support them socially and make sure they're having access to additional care. I think all of those are very important strategies to think about. So what has been proven to improve adherence to therapies. Obviously, education of patients, educating them on their treatment, what the regimen is like, what the toxicities are like, when they should reach out to their providers because they're experiencing some side effects, and what constitutes an emergency where they need to just go to the emergency room right away. Obviously, very important factors that are involved in educating patients about those toxicities. Also, when we're thinking about our patients who have incurable cancer, early referral to palliative care has really been shown to improve quality of life, making sure that we're managing patients' side effects, their nausea, their vomiting, their diarrhea, any pain they may be having is obviously very critical. And to look at this over the course of their metastatic journey is obviously also very important. I think many of us have psychiatrists and psychologists that we work with. We need to screen patients for anxiety and depression, refer them to specialists as soon as possible so that we can help them manage their distress and improve their quality of life. And then, there are many other supportive care services that can be helpful. Smoking cessation, sexual health, how our cancer therapies impact intimacy are obviously very important for many of our patients, as many of them are quite young. And then, encouraging patients to keep track of their side effects. And again, sometimes it's hard to always remember, maybe just writing them down and having them on hand whenever they come to see you or their APP to discuss. So I don't know, Dr. Matani, if you have other thoughts or that you'd like to share here.
Yeah, I think you've brought up really important points. The only thing that I would add is we should fully utilize all members of our team. Many patients can sometimes feel a little bit shy about telling us as the physician all of their side effects because they perceive us as very busy, or they're worried that if they are totally forthcoming in all of the things that they're experiencing, that we may discuss dose reductions, and in their mind, a reduction in the dose may equate with a less effective regimen. I think patients often equate toxicity with efficacy, and that requires a fair bit of education. There are a lot of studies that have shown us with various different regimens that a dose reduction doesn't necessarily impact the effectiveness. But many of our patients have those discussions with our APPs or our navigators or our infusion nurses, and sometimes they come to us and give us that information. So what I've done routinely is to try once in a while to take a walk through the infusion room. If you have a minute in between patients, not that we have many minutes these days, but I think it's time well spent, or on your lunch break, if you just walk around the infusion area and see your patients and chat with the infusion nurse and say, how are things going? Did she mention anything to you? You pick up really valuable pieces of information.
That's really great advice, Dr. Matani. I can tell you're a wonderful physician, and I'm sure your patients love you very much. So I'm going to just wrap it up here in the next few minutes to leave some time for a presentation at the end. Again, as Dr. Matani said, really utilizing all of the members of the healthcare team. I have to say my patients reach out to my nurse almost daily with any issues. And so encouraging them to stay hydrated if they're having diarrhea, make sure that they're, modifying their diet to help mitigate the side effects of some of these therapies, frequent small meals, taking antidiarrheal agents early and not waiting for toxicity to get worse. Again, nausea and vomiting. Again, it's very important to stay well hydrated, but if patients are having struggles, you can bring them back for some fluids in the clinic. And then making sure that we're adjusting their antiemetic regimen to really optimally manage their nausea. And then for fatigue, tell patients it's okay to take a nap or some breaks from time to time, and making sure that they're getting enough sleep at night is obviously very important. As I'd already mentioned, patient-centered care, palliative care is critical. palliative care is not something that we should be thinking about at the end of the metastatic journey. It should be something that we're thinking about at the very beginning, because we have the ability to greatly impact quality of life, improve side effects for our patients, and just working with our multidisciplinary teams. Very important, engaging with APPs, the nurses, dietitians, social work, palliative care, if you have a palliative care clinic, referring patients, the psych oncology program, psychiatrists and counselors who are available, chaplains, pharmacists. I am very fortunate to have a PharmD in clinic with me who really spends a lot of time helping to educate patients and think about mitigation of side effects. So all of these things are just so important. And really thinking about palliative care the moment somebody presents to your clinic early on in their metastatic journey. And so, again, as I mentioned, there are other aspects of a patient's quality of life that we can impact. Fertility in a patient who's got metastatic disease obviously is challenging, but I've had patients who have metastatic disease and maybe have the option for adoption or surrogacy, particularly for those patients who we expect to live a very long time with their metastatic disease, notably HER2 positive metastatic disease. These are things that we can talk about, can be very challenging, particularly if we don't really know where a patient's going to sort of fit in that trajectory of metastatic disease, but definitely something that can be readdressed over time. To ensure that we're checking our patients for anxiety and depression and referring them out to our psychology and psychiatry colleagues for help. Peer support groups are obviously very helpful for some patients, and that is a consideration as well. And then making sure whether it's a formal assessment. I will say I do not do formally validated tool assessments in the context of patients who are not on clinical trials, but we certainly can assess our patients' quality of life and think about alternative strategies for stress reduction and improvement in quality of life. A number of supportive care measures for our patients, obviously smoking and alcohol cessation, having a healthy body weight, improved physical fitness can all lead to improved outcomes. Having patients meet with nutritionists to optimize their diet so that they have more energy and are managing a healthy body weight. For some of our patients, it's actually, losing weight. For some of our patients, it's actually maintaining their weight, particularly if they're struggling with some of the symptoms of their cancer. Thinking about genetic counseling and genetic testing in these patients, I think many of us are doing genetic testing across the board in all patients with metastatic disease, because obviously it can open up the door for PARP inhibitor therapy. I think in the HER2 positive space, as you all know, PARP inhibitors aren't FDA approved in this setting, but maybe certainly capturing patients who have hereditary syndromes because their family members can potentially benefit from knowing if there's a mutation running in the family, and then making sure our patients are staying healthy. Immunizations for COVID, for flu, obviously are very important for our patients, because we don't want them to come down with anything while we're trying to manage their disease. And then in terms of thinking about managing patients with metastatic disease, obviously it requires a multidisciplinary approach. I would say this approach here is more broadly applicable to early stage breast cancer, but obviously in patients with advanced stage disease, sometimes we do think about things like palliative radiation therapy, particularly to an area of oligoprogressive disease or a place which is causing pain, or if patients have had a pathologic fracture. That is obviously very important to think about. Surgery is not common, obviously, in patients with metastatic disease, but sometimes palliative surgery can be impactful in terms of improving quality of life. But we've got a team of pathologists, palliative care folks, social work, psych oncology program, all which need to work together for the best of our patients. And Dr. Matani, I don't know if you'd like to add in any comments here, anything that I may have missed.
Well, not that you missed, but just kind of echoing the statements that you've already made. I think for patients, as you mentioned, in the early stage setting, it's more common that they frequently meet with various different types of physicians. And in that regard, I think it's been very useful to just start that first visit with explaining to them what everyone does and what their role is in their care. Because, for example, many patients are very confused about what a radiation oncologist does, and they think it's a radiologist. But just making that distinction, explaining to them the types of therapies that could be offered. I think the other thing that really comes up quite a bit when you're in a community practice is having physicians that are not necessarily working under the same roof, taking care of patients, and patients feeling overwhelmed by this feeling that they have to coordinate their care. So little things like, making sure that your note gets sent to a colleague who's not on the same EMR system that you're on, or even picking up the phone in front of the patient and saying, I'm going to call Dr. So-and-so just to let them know what's going on. I think for our patients, they really appreciate not having to be that go-between when all of the providers are not sharing the same EMR system.
That's great. Really well said. And I think with that, we will turn it over to Novelia to discuss.
Awesome. Thank you so much. Hey, everyone. My name is Shashi Shankar. I am the CEO of Novelia, and so excited to share a little bit more about what we do. So in a nutshell, Novelia is a free tool for patients to use where they're able to access all of their health records across the past 10 years simply by sharing their name, gender, date of birth, and their address. Again, it's 100% free, and the way Novelia works is that we use the patient's unique demographic information, again, just their name, gender, date of birth, and address, to digitally locate all of their health records across the past 10 years. It's really simple, it's faster than brewing a cup of coffee, and patients really benefit from having all of their health records right at their fingertips. When we think through things like a multidisciplinary approach to care or being able to engage in shared decision-making, we believe that empowering patients with the knowledge of their own health history goes a long way. What does the Novelia platform actually provide patients? Well, I wanted to provide a very quick look at the sort of data, the sort of records that patients can expect to enjoy and appreciate on the Novelia platform. So you see here everything from allergies to immunizations to medications to documents. What patients really appreciate about Novelia is it's up to date every single day. So, for example, if I were to see Dr. Matani the day after tomorrow, my records from that visit would actually be up to date. You see things like the medications that you're currently on, the dosage, the administration, the manufacturer of that medication. You even have the ability to look up notes from that visit. So patients no longer have to track and manually save all of those records and notes. They can sort of follow their health in real time and share that data with new physicians as well. So sharing this tool in case it's something that you believe your patients could benefit from, as we've seen a lot of folks across the country appreciate this as well. So thank you for taking time to learn a little bit more about the Novelia platform.
Excellent. Thank you, Shashi. We appreciate all the questions that have come in, and we are going to take a moment in our remaining few minutes and try to answer some of those. We had a great question from Kimberly. How do you foster your patients to accept palliative care early on? I think this is a question that is for caregivers as well as providers of care. Dr. Matani, I see you shaking your head. Tell us what you think.
Yeah, I think that this is a tough one because a lot of times providers who do palliative care also see patients when they're making a hospice decision. And many of our patients equate palliative care with hospice, and they think that we're telling them that they're at the point where we've decided to pursue comfort approaches. So I think that recognizing again the importance of the multidisciplinary care team and recognizing what everyone's role is early on and introducing it early on is essential. I refer all my metastatic patients very early to palliative care, even if they really don't have a lot of needs, just so that they can make that connection and they don't equate it in their mind to something that I'm not saying. I don't know, Dr. Nanda, if you feel the same or you approach it differently.
Yeah, I think, for my patients who have some symptom, pain, for example, or struggling with weight challenges or appetite stimulation, I probably have a tendency to send them early. Sometimes for patients who come in and they're doing fine, I just wait and see how things go before I involve another provider, because the last thing I'm looking to do is just add another visit that's not going to be helpful. But certainly for my patients who I feel could benefit from more intensive monitoring of symptoms, management of symptoms, if they've got pain, then I certainly do send them early on. So I don't necessarily send everyone the moment they walk in my door, but I do like to incorporate it early on, because when that time comes, for many patients where we need to make a transition to more less therapy but more supportive care, then it makes that transition a little bit easier because they're with a provider who they know.
Yeah, agreed. Absolutely.
Excellent. Thank you. And it looks like we have time for one more. There was another question from Anne. How about the use of ESAs to help with fatigue if hemoglobin is low?
So I actually do not use ESAs for my patients with metastatic disease or any breast cancer patient. This has actually been shown to worsen outcomes. So my standard of care is to give blood.
I agree.
Excellent. Thank you. And then last question that we have is, how do you anticipate the practice will change in the adjuvant setting based on the treatments currently under investigation?
Well, I'll start by just saying that I think that we are gradually moving many of our therapies that we utilize in the metastatic setting up to the early stage setting, recognizing that if the treatments are really very impactful in the metastatic setting for an appropriate selected patient in the early stage setting, there may be an opportunity to utilize that therapy earlier on. For example, we now utilize TDM1 in the adjuvant setting, and there's an ongoing study looking to see if in a high-risk population, TDXD may be a better strategy. So I think as we move forward, we'll see that general trend of many of our therapies that we're utilizing in the metastatic setting moving up. But then it also begs the question, as we then do have patients who develop metastatic disease, many of them will be exposed to a lot of these treatments. And what does that portend for them in terms of the expected outcomes? That'll be a challenge.
Absolutely. Great points. Thank you very much. Well, friends, our time has come to a close. We'd again like to thank Prime, Novelia, AstraZeneca, and Daiichi Sankyo for supporting today's educational activity. Also, a huge thank you to our expert faculty panel today, Dr. Reshma Matani and Dr. Rita Nanda. You both did a fabulous job educating us on the latest information today. Thank you very much. And lastly, thanks to each of our participants, all the folks in our audience who have joined us today to take time to learn with us. We hope that you found today's program both informative and enjoyable. And this concludes today's webinar. Thank you and enjoy the rest of your day.